Hello, I'm Dr. William Berger, owner and founder of Northeast Medical Practice. We are a concierge-style internal medicine, weight management, and aesthetics practice located in Great Neck, New York on Long Island. And as you may know, October is Breast Cancer Awareness Month, so I wanted to take a few minutes to talk about screening for breast cancer in women. So this has changed a bit over the years as it's been found that the risk for breast cancer is increasing, and also the number of cases in women under the age of 50 has increased. So for that reason, the guidelines, instead of starting at age 50, have decreased down to the age of 40 in most cases. I'm going to talk about the American Cancer Society guidelines here today, but I'm also going to give you just some of my own personal opinions as a physician about this and how women should think about breast cancer screening and speak to their physicians about it. So currently, from age 40 to 44, a woman can consider, it's an option, to have an annual mammogram. I personally think it's a good idea to begin at age 40. This usually covered by insurance. It can be a little bit variable, but I really do think that it's a good idea, given the current incidence of breast cancer, for women to begin screening if they have average risk for breast cancer. And I'll chat a minute about what it means to have higher risk for breast cancer. But if we're talking about the average population of women, I think it's reasonable to start at age 40 with an annual mammogram. ACS does recommend between the ages of 45 and 54 to definitely have an annual mammogram. Above the age of 55, the ACS recommends either as an option or biannual mammography for women of average risk. And of course, that's assuming that they're in good health. They say within a life expectancy of 10 years. That's usually how these guidelines are written. But the way I like to think about any kind of screening test for cancer or anything else is, if we were to, God forbid, find something, would the patient be a good candidate for treatment? And also, of course, would the patient want treatment? For example, in a very much older person, to do a colonoscopy comes with risks, requires sedation or anesthesia. Of course, there's always some risk of perforation of the colon and whatnot for anybody going for a colonoscopy. But if we're talking about someone in their late 70s, early 80s, maybe they're not in the greatest of health and they aren't a great candidate to go under anesthesia, or they're in good health, but they really just would not want to undergo any kind of treatment, regardless of what could be found on a colonoscopy. So it's always what we call a shared decision-making kind of situation with the patient. It should be at all times, not a paternalistic top-down kind of recommendation from the doctor, but an open discussion with the patient. So in the instance of breast cancer, it's a similar kind of situation. It's a discussion to be had with the patient. Would they actually want to act upon any positive findings from mammography or other means of imaging the breast? There's been back and forth, and for quite a while now, either self-breast exam by a woman or clinical breast exam isn't within the guidelines anymore. It isn't technically recommended. However, a woman should certainly be aware of any breast changes. So my feeling is that they're recommending against this because women might forego a mammography session because they didn't find anything on their breast exam themselves. But of course, it's simply not as sensitive a diagnostic tool as mammography is. So certainly a woman should pay attention to any changes in her breasts and speak to their physician about it, but it definitely should not ever prevent a woman from pursuing the annual or biannual mammography that would be recommended for her simply because she hasn't noticed any changes in her breast. Because mammography can find cancers a year or more before they actually are able to be detected just by touch and before there's a lump, in other words. So there have been advances in mammography over the years. One of them is so-called three-dimensional or 3D mammography. I'm talking about digital tomosynthesis. Most breast imaging centers have this option. The 3D mammogram is more sensitive and finds more cancers than the 2D mammogram does. So this is what I try to order if I'm sending a patient to a center that has 3D mammography. It tends to result in fewer callbacks to double check a screening finding with a more directed diagnostic mammogram of that part of the breast. And so basically, I think it's a good idea to obtain it if you can. It is a little bit more expensive than a standard two-dimensional mammogram, and so if that's a concern, you might want to chat with your insurance company about coverage and things like that before you go for the imaging. But I do think it's a significant advancement in the sensitivity of mammography and should be obtained if possible. So let's talk about high-risk women. Women at risk that's elevated for breast cancer. So the guidelines basically state if the risk is 20 to 25% or greater than 25% certainly, then breast MRI would be recommended for the patient. The way that this risk is estimated are by a variety of clinical tools that a physician can use to make that determination. They're largely driven by family history, but also any personal history of whether biopsies have been done in the past, things like that. They do come up with slightly different values for the level of risk, but those are what should be utilized and discussed with your physician to determine your risk for breast cancer. And again, if it's 20 to 25% or more, breast MRI should be considered, and hopefully insurance would be willing to pay for it because of that particular risk score from one of the calculators. Of course, if a patient has had genetic testing and they have a BRCA1 or BRCA2 mutation, then that's definitely a reason to have breast MRI performed. If a patient has a first-degree relative, and so I'm talking about a parent, a child, a brother, or a sister with a BRCA mutation, of course, it would be a great idea for the patient themselves to be tested. Whether or not the genetic testing has been done, they merit a breast MRI to take a very close look for any breast cancer. Patients that have had radiation to the chest for whatever reason, under the age of 30, are at increased risk for breast cancer due to that exposure. Particularly if it's young, for things like Hodgkin's lymphoma, for example, those cells have had time to have mutations caused by the radiation and time to grow. Under the age of 30, if you've had any radiation to the chest, you do merit a breast MRI. And there are a number of genetic syndromes that increase risk for lots of different cancers. They're usually due to mutations in the genes that help suppress tumor growth. Li-Fraumeni syndrome is one of them, but there are several, and for patients that have those, they should already be hopefully followed by an oncologist and be screening for the various cancers that these syndromes can put the patient at risk for, but those folks would definitely merit a breast MRI as well. And so now I just want to discuss a more gray area with regard to risk for breast cancer and whether or not a patient might merit a breast MRI, and that's dense breasts. So if in a woman who has dense breast tissue, then they are at increased risk for breast cancer in the sense that it's more difficult for a mammogram to detect a cancer because of that dense tissue being in the way, essentially. If the radiologist has read the screening mammogram as heterogeneously dense or extremely dense, in my mind, that's a situation where the patient and or physician ought to be pushing for a breast MRI. This is kind of a gray area, as I said, and so insurance coverage may be spotty for the breast MRI, but I really think that that's kind of where the guidelines are eventually going, and that they should go in that direction, because we already do know, in fact, that having heterogeneously dense, meaning there's a lot of density throughout the breast, or it's just extremely dense tissue, that it's more likely that a mammogram will miss a cancer because of the density of the breast tissue. So in those instances, it should definitely be discussed, and part of the reasoning for me to put out this video is for women to more strongly advocate on their own behalf with their physicians. Not all physicians are necessarily up to date with all these recommendations, and also the more kind of edge of the envelope things like density of breast tissue and whether MRI is advisable or not. So it's also important for women to advocate on their own behalf, and that's part of the reason that I wanted to put out this educational video. So, as always, these educational videos that I put out there are for educational purposes only, and no doctor-patient relationship has been established, and they should not substitute for or be interpreted as medical advice. If you have specific questions or concerns about your health, please don't hesitate to reach out to your medical professionals. If you'd like to know more about the concierge-style program that we have here, which includes a very deep and broad cancer screening program, please contact the office, 516-604-341, or online at northeastmedicalpractice.com. You can reach out to us through the website. And of course, all of these kinds of educational videos and talks I provide on our social media platforms, as well as our YouTube channel, where I'll be posting this video, and also on my Longevity MD podcast, which is hosted by Spotify. And there you can learn about all different aspects of health optimization that I discuss with other clinicians, and I also give individual talks on, and basically learn more about how you can be more proactive in terms of your own health, your quality of life, and your length of life. So until we see each other next time, consider that it's Breast Cancer Awareness Month, and get your screening if appropriate, and be in good health.